Okay, I think, good morning, everybody. I think we'll go ahead and get started. I know we'll have some folks that will still join us through the course of the webinar. Before I begin with this team, can I just make sure the attendees can hear me and the sound and audio is fine? Maybe one of the attendees can put a thumbs up or a comment in the Q&A and just let me know that you can hear us and that everything is fine. Okay, perfect. Thank you very much for that. So let's go ahead and kick off. First of all, a great good morning, good afternoon, and good evening to all our patients, caregivers, and healthcare workers attending today's webinar, Sickle Cell Disease and Lung Health. My name is Sanjeev Wadhwani, and I'm a board member for SCAGO. I lead the research committee and a volunteer in this organization. It's estimated that while 6,000 patients impacted by the devastating complications of sickle cell disease are in Canada, nearly 60% of those patients are right here in Ontario. So we also know that many patients living with sickle cell disease are impacted with pulmonary or lung complications, and estimates suggest that around 30 to 40 patients, in fact, have these types of complications. Next slide, Joy, please. So in today's session, we have an excellent panel, which we'll introduce shortly. First, I'll cover some housekeeping items, logistics. I will then transition to my co-moderator for today's session, Dr. Joy Imbru, who will cover the objectives and introduce our esteemed speakers. Following the speaker presentations, we will make time for Q&A, and your questions and feedback are extremely important to us, and we really hope for an engaging conversation. And then we'll bring the session to a close. Importantly, at the end of the session, when you exit the webinar, you'll be directed to a survey. And this survey is very important to us. It's very short. Your feedback is extremely important to us. This team goes through every comment, every amount of feedback, because what we try to do is discuss it internally and see how we can continue to bring sessions like these, educational sessions, to you and to the community. And so sincere thanks in advance for completing this. Next slide. So before we begin, just a few housekeeping and logistics. So we'll record the session, so it's made available for reference or for attendees who could not attend today. We'll mute all the attendees to avoid any background noise for the speakers. But if you have any questions as you hear the speakers and the presentations, if you could use the chat feature, which is at the bottom of your Zoom window, you'll see a Q&A button there. If you can put your questions in that feature, as we go through the presentations and as we open up the Q&A session, we will triage those questions and we will be able to answer those live. And if there are some questions where we need to come back to any of the attendees, we will certainly do that after the session as well and work with the speakers to get any information even after the webinar. So first, I think before we introduce our speakers, I'd like to first introduce my co-moderator, Dr. Joy Imbru, who is a SCAGO board member and leads our Quality of Life Committee. So Dr. Imbru, over to you, please.
Thank you, Mr. Wadhwani. Good morning, everybody. It is my pleasure to be here with you this morning, and for some people, it's in the afternoon. And thank you that you could join us for this session. I will go straight to the land acknowledgement. We wish to acknowledge that the land from which we operate is located on the traditional territory of the Mississaugas, as well as the Anishinaabe, Wendat, and the Haudenosaunee people. This land has been governed by the dish with the one spoon wampum belt for 1,000 years, and in recent times by the Williams Treaty and Treaty 13. Welcome to this webinar this morning, and I will go ahead and introduce our first speaker, give the objectives of the session. Our plan is to share and discuss research findings on the impact of hydroxyurea on reducing deterioration in sickle cell disease and insights on how to keep your lungs in optimal health. And our first speaker this morning is Dr. Smita Pakhalè. Thank you for being here, Dr. Pakhalè. We are very privileged to have you this morning. Dr. Pakhalè is a clinician scientist at the Ottawa Hospital and the Ottawa Hospital Research Institute. As an adult pulmonologist at the University of Ottawa. She's been there since 2008. She's leading community-based research projects at the Bridge Engagement Center 225 Donald Street in Ottawa, Canada. The bridge conducts research projects in true partnership with people who have lived experience of poverty, homelessness, at risk for homelessness, and low-income racialized population, including the indigenous people. The bridge has designed and operationalized a patient engagement model, which has been acclaimed internationally. Dr. Pakhalè completed her post-graduation training in internal medicine at the Columbia University at NYC and later did fellowships at the University of Toronto and University of Manitoba in Canada. Most recently, she's completed a master's degree in epidemiology and biostatistics at the McGill University in Montreal, Canada. Welcome, Dr. Pakhalè. We are looking forward to hearing from you. The floor is yours. I will stop sharing so that you can share. Welcome.
Thank you. Thank you so very kindly for that very generous introduction. And I encourage everybody to, ask questions and make it very didactic so that we have discussion rather than just me talking, because the issues are very vast and I'll try to cover as much possible. And again, thank you for inviting once again for this very interesting and very important webinar on a topic that most often remains unacknowledged or not get too much attention. I do not have any disclosures for the current talk. So what is sickle cell disease? I mean, most of you in the attending know that it is a hereditary disease. It's a multi-system disease. It's a life-limiting disease of hemoglobin, which carries oxygen for us. It predominantly affects racialized minorities, and that's not true just in Canada, but United States and rest of the globe. Worldwide, there are about 30 million people, and it present in Sub-Saharan Africa, India, Saudi Arabia, Mediterranean countries, and as you know, in North America. In Canada, we do not know actually how many people exactly are there. This is the estimate. Sanjeev said 6,000, 5,000, maybe there are more than that, but we do not have any count, actual count. And most of these people are living in Ontario. And we did some analysis in Ontario, rather SCAGO did analysis, and 80% of these people fall in the lowest 3 income quintiles. And that means sickle cell disease is not the disease of racialized minorities, but it's a disease of low income racialized minorities. And it is a very important point for us to note. So furthermore, we know that sickle cell gene with hemoglobin S, it's at least one sickle cell gene we need to have to carry to have the disease. And there are major types like the hemoglobin SS, but there are other types, which is hemoglobin S and beta thalassemia, etc. And you know this basic knowledge of sickle cell disease as such. And this is the genetic kind of a descriptors of the sickle cell disease. But you could be also sickle cell carrier, carrying just one gene. And we have some research on that people with sickle cell trait also can get some clinical presentation. So we need to be aware of that. Now, I was telling you about the global presentation of sickle cell disease, and it is present in many, many different countries. So what causes it is the point mutation, just one point mutation in a gene for hemoglobin. And that's all it is. And that has a lot of similarity with some other diseases I'll go over later, and differences as well. The sickle-shaped cells, they can easily then stick together because they are not their normal oval shape. And they cause, by sticking together, blocking up the blood vessels and painful crisis, destroying the blood vessels because they are sticking together and not protected, and eventually cause different organ damage. The pathophysiology of sickle cell disease shown here pictorially, as you can see, the cells which are now sickle, not oval in shape, they stick together rather than flowing normally through the blood vessel. And by causing the blockage of the blood vessel, the blood supply to the organs is blocked, and that causes infarction, which is death of cells in that organ. It could be any organ in the body, but of course, when blood supply to some organ is gone, you get acute pain in the joints and bones, and the acute chest syndrome, in the spleen, the bone destruction, osteonecrosis, and also kidney damage. There is an intense inflammation in this process, and that causes further some other damage. And if this is happening in the lung, as you can imagine, all the blood goes through the lung every cycle of your heartbeat. And if there is a blockage there, you can imagine how devastating the effects will be on the rest of the body, because blood getting oxygenated in the lungs. So there are different lung diseases which can happen by this pathophysiology. This is a vivid picture that shows the painful swollen hands of little kids, and you can imagine how painful that must be. And such kind of a crisis of blocking blood vessels can lead to different organ damage, as I was telling, but it can be stroke and including premature death. This second picture shows how the liver and spleen is affected and hence enlarged because of the associated inflammation. And you can imagine the kid will be in a lot of pain and also suffering. So the clinical course is quite varied because, as we saw, sickle cell can affect any organ because blood vessels are all over our body. So it can cause, first and foremost, a lot of anemia because the blood vessel carrying capacity of the cell is now less. It can cause the painful hands, like I was showing you in the previous picture. It can cause painful acute crisis with pain in chest or legs and bones. And the common is acute chest syndrome that we all know. And with all these, there is a risk of increased organ damage, as I said, lungs, kidney, bones, joints, brain, heart, etc. And with that, you get repeated bacterial infections. And because you have anemia, you need a lot of blood transfusions, so complications associated with that. And because there is a chronic pain, the addiction to pain medication is very likely, and associated mental health issues, and of course, premature death. So it's a devastating disease with multi-organ involvement over the course of the life. And heart and lung complications cause 45% of the deaths in adults living with sickle cell disease. So lung complications like acute chest syndrome, obstructive lung disease, restrictive lung disease, and pulmonary hypertension are the common occurrences in sickle cell disease. And I will shine some light in what these medical jargon terms mean in a very simple language. The acute chest syndrome, it's a painful syndrome. It's the second most common cause of hospital admissions for patients living with sickle cell disease. Patient can present with fever, increased respiratory effort, meaning breathlessness, increased rate of breathing, and chest X-ray could be abnormal, and they could have wheezing, chills, they could have cough, and many of these patients could also have asthma. Now, wheezing is a hallmark of asthma, but also patients with sickle cell disease present with wheezing, So you can see right away how the diagnostic dilemma could play out here. So most importantly, you need to remember that sickle cell disease patients, about 90% of them can have abnormal lung function tests. So that's like almost everybody getting some kind of lung involvement in some or the other form that I was listing earlier. So the abnormal lung function test is a test which measures the physiology of your lung, how much you can run, how much you can do something, how much your lungs carry, how much you're carrying oxygen carrying capacities, etc., how much is your total lung capacity, how big are your lungs, and all of this could be abnormal in 90% of the patients. So that's quite a striking number. So asthma is pretty common, as I was saying, with sickle cell disease. And is it a risk factor and more for increased morbidity and mortality itself in sickle cell disease? So if you have sickle cell disease and associated, you also have asthma, your chances of being sick are higher and your chances of being dead are higher. So 78% of patients demonstrate obstructive lung disease, which is the hallmark of asthma, on their pulmonary function test. And 60% of the people with sickle cell disease have wheezing. So when you have sickle cell disease with asthma, as I was saying, you have higher risk of vaso-occlusive pain crisis, you have higher risk of acute chest syndrome than patients, those who do not have asthma. And if you have wheezing associated, then over 118% of people, 18% increase in emergency room visits because of pain crisis, and about 158% increase in emergency room visits because of acute chest syndrome. So these are very devastating statistics, and we must know more about wheezing and asthma in sickle cell because we can control those, we can treat them better. And these chronic lung complications I was telling, it's not just asthma and obstructive lung disease like asthma, but also restrictive lung disease, which means your total lung capacity is reduced in about 50 to 75% of the people. So there could be scarring of the lung, or there could be no scarring of the lung, and the restriction is because of the chest wall involvement. As you know, people with sickle cell disease get very many acute chest crises, which just is a lot of inflammation in the soft tissues around your chest wall, muscles, and fascia. About 30% of people also get pulmonary hypertension, and 20% mild and 9% about moderate to severe. So this is also very devastating disease to understand. We all know the blood pressure, the systolic blood pressure and all diastolic blood pressure that we have. These are very high numbers. These are the blood pressure in your blood vessel in your rest of your body. But in the lungs, the blood vessels have very low pressure. This is a low pressure system. So when the blood pressure increases in these blood vessels inside your lung, that is called pulmonary hypertension, and that's a very devastating disease. About 13% of people could have only reduction in their diffusion capacity, which diffusion capacity measures the oxygen carrying capacity of your lungs. And that's, again, itself can be devastating, and people might need oxygen supplementation just because of that. Almost everybody, as you know, with sickle cell disease has exercise limitation. Now, the pulmonary hypertension I would tackle here is increased blood pressure, as I said, in the blood vessels inside your lungs. And it can cause shortness of breath, dizziness, fainting, fatigue, chest pain, swelling. And as you can see, all these symptoms are also symptoms when you present with acute chest syndrome. So again, a lot of diagnostic dilemma. So you need an astute physician to make sure they diagnose you with these different associated conditions. So the pulmonary hypertension could be progressive and life-limiting. The survival, if you have pulmonary hypertension, is very limited, as this table shows. People without pulmonary hypertension and with pulmonary hypertension, their 1-year survival, 3-year survival, and 5-year survival is quite limited as compared to if you do not have pulmonary hypertension. So diagnosing these entities is important in timely manner. The prognosis of sickle cell disease with chronic lung involvement, again, as I was telling, has increased morbidity, increased diseases, like you were saying, increased lung involvement, increased emergency room visits, increased pain crisis, and increased premature death. So sickle cell, as I said, is multi-system disease, life-limiting disease, progressive disease, and a genetic disease with one single mutation. And those all characteristics are also true with another disease called cystic fibrosis. It is also a progressive disease and declines your lung function. It also causes a reduced life expectancy. However, the comparison with sickle cell disease and cystic fibrosis doesn't stop there. The decline in lung function in sickle cell disease is much, much higher. And also, you have reduced funding for sickle cell disease, and there is less research on sickle cell disease than cystic fibrosis. So treatment for chronic lung involvement is your standard asthma treatment for asthma, but the diagnosis is important, as I was saying. But restrictive lung disease and pulmonary hypertension do not have specific treatment. But if you know them, that they are present, you can do a lot of other supportive management. So the asthma needs to be treated well. First is the diagnosis, and the diagnosis is challenging, as I kept telling repeatedly. However, if you diagnose it properly and treat it properly, you can reduce the hospitalization and emergency room visits. People can also have reduced chest syndrome, and need for oral steroid will be reduced. So we urgently need some national guidelines, as you can see, to specifically diagnose sickle cell disease along with asthma. So to do this properly, we need multidisciplinary clinics like we have for cystic fibrosis. We have multiple professionals seeing cystic fibrosis patients, like lung doctors, nurses, nurse practitioners, diabetic doctors, ENT doctors, etc. But in sickle cell, we do not have that available at multiple centers, including major cities. Like in Ottawa, we don't. So we are trying to fight to get these multidisciplinary clinics, because it can reduce the total healthcare cost, it can reduce emergency room visits, it can reduce I thought I put my phone off, but not really. The gadgets. And that's not even my phone. I don't have one. So getting back to the sickle cell multidisciplinary clinic, about 40% reduced emergency room visits, 5 times less hospitalization, reduced hospital length of stay. These are all very good statistics that any hospital administrator would be, attracted to, because that ultimately reduces the cost, the healthcare cost. And so this is the right thing to do, having multidisciplinary clinics for sickle cell patients. So the most common comorbidity reported in patients with sickle cell disease, as you must have seen during this pandemic, was asthma. And you can see, if a sickle cell disease patient have asthma, they don't even know it. And if they do get COVID-19, that would be very difficult outcome. And we do not even know a lot about it. I just found this reference in Medical College of Wisconsin, but I do not know if a lot of people are keeping data on this, and how many of the sickle cell patients know even that they have asthma. So the overall prognosis of sickle cell disease, as we know, is quite devastating. It's a life-limiting disease. The life expectancy is reduced. People with sickle cell disease live 30 years less than that of the general population. The median age of death in the US is 42 years in male and 48 years in females, and these are much less than cystic fibrosis, I can tell you. In Jamaica, 53 years in males and 58 years in females, and rest of the places we don't even know, because we do not have data, we do not have research. So the child to acute adult care, again, the transition to care is very important, because a lot of sickle cell disease patients get lost in the transition. They get followed in the pediatric hospital, and then to go to the adult hospital, if there is no transition plan from the pediatric hospital to the adult hospital, they fall through the crack. you must remember, right, what I said right at the get-go, that 80% of the people with sickle cell disease come from low-income background. And if you come from low-income background, you can imagine when you become 18, you are facing a lot of different things, if there are already family issues, income inequality issues, you want to find a job, you want to the schooling, or you might have dropped out of school, or you want to go to school, but you cannot because your sickle cell is so devastating. And there are a lot of issues happening during that transition to the adulthood. And on the top of that, if you have a disease like sickle cell disease, which is so devastating, your rate of falling through the crack is very high. So the transition of care itself is a very important issue that we must pay attention to. Because if you lost to follow up during those growing years, you would have more devastating organ damage and higher emergency room visits and hospitalizations for sure. So as you can see in this graph, I know it's a busy graph, but what I wanted to show you, this inflection point that life expectancy has increased, around the time when there was more funding for sickle cell. And since there was more funding for sickle cell, more clinical care got better. There is a little bit more research better, and all these things. So it is literally tied to funding. If you have more funding, you have more personnel, they can do more research, they can do more comprehensive, multidisciplinary clinics are possible if there is more funding. So that's what we need to fight for, because as compared to cystic fibrosis, sickle cell disease gets very little funding. As you can see, there are a lot of different complications sickle cell disease patients suffer from, just simply because of the blood transfusion. Because there is not a lot of definitive therapy for many, many years, people with anemia just get blood transfusions. And if you get repeated blood transfusion, it affects a lot of different things. Usually in these studies, there was quality of life was not measured, but you can imagine if somebody is having so many complications with blood clots and complications because of the blood transfusion, your quality of life is definitely much, much reduced. But we need more studies to measure that. Penicillin prophylaxis came on early on because, as I was saying, the sickle cell patients are very, prone to get complications. And this is one reason is because of their spleen is many times not functioning as well. Their oxygen carrying capacity is less, their organs are deprived of oxygens, and children less than 5 years, the risk of pneumococcal infection is very high. However, if you give them penicillin prophylaxis, it is reduced phenomenally. But over 5 years, that risk is not similarly reduced, So the complication rate is still there. The infections are still there, but penicillin prophylaxis doesn't help them as much. So we need more tools. Then came hydroxyurea, as you all know. And this drug, though reduces complication like painful crisis compared to the placebo, it also has some side effect. And I know we have a special talk on the hydroxyurea itself, but it's the only drug proven to modify the clinical course. And we do not have a lot of means to treat a lot of things. Like I was telling you about the lung disease, we need better tools to even diagnosis, like better guidelines. And that comes from a lot of research. So the long-term effect and safety, effects of hydroxyurea, we know it is quite well tolerated, but still we need to learn more. And that kind of research only can come with more healthcare dollars. But hydroxyurea can prevent end organ. At least we know some data, but it's not clear yet. So new therapies are approved in United States, as you know. Some of these therapies, the glutamine and crizanlizumab, but we do not have these in Canada yet. And you might know these kind of monoclonal antibodies are kind of therapies which are very, very expensive, are approved for different kind of cancers with very minimal effect, and many different diseases. But sickle cell therapies are not approved in Canada yet. So the bone marrow transplant, gene therapy, and gene editing are on the horizon, and they are set to be curative procedures. and increases survival. However, as you can imagine, they are very high-risk procedure, requires a close match donor, and only available in a very, very specialized centers, because you need very, very specialized care even after the procedure. And also the patient characteristics, the social environment, and all those go in the equation in selecting patients. So very few patients qualify for that. And again, funding is a major issue. Social safety net will be a major issue, even if these things become available later on. So the available treatments to prevent the pain crisis, the treatments to prevent complications, treatments to improve quality of life, treatments to improve longevity in sickle cell patients, treatment to reduce discrimination. I am saying that with a tongue in a cheek, but that's very important, because as we know, people from low-income background, people with racialized background show up to the emergency room with pain, and they get labeled as drug seekers, and their suffering and pain get not attended in timely manner. And this happens even today. People tell us devastating stories of such discrimination in the emergency room even today. So we do not have much treatment on these, and if we need to do more, we need to come together and reduce health disparities eventually, because treating sickle cell disease properly is reducing health disparities. Because there is a healthcare gap, as you can see, I demonstrated some of it with sickle cell disease and cystic fibrosis. Though they are similar diseases, there is a vast difference in funding, in how much you get. And the stereotyping, stigmatization of sickle cell patients, because of not much knowledge about sickle cell disease and the devastating complication in the day-to-day physicians, even in emergency room physicians. And that's why more stereotyping happens. So treating sickle cell disease properly, having proper research in sickle cell disease equates to health disparities. And there are a lot of efforts, as you know, SCAGA is the one. There is a national effort at the Canada level for sickle cell disease. There are some other organizations. They are doing a lot of their share, but these are all citizen, led efforts, and we need a more healthcare involvement and engagement in care of sickle cell. So the take-home messages for me: the most common autosomal recessive disorder, commoner than cystic fibrosis. Treatment options are very limited, and the rate of complications is very high, and people die prematurely, losing, very productive years of their lives. Median age of death is around 40 years, according to some research in Canada, but we do not have good research. And acute and chronic lung complications are very common. They are underappreciated and hence underdiagnosed, and they cause increased complications and premature deaths. So we must have some multidisciplinary, patient-centered, comprehensive clinical care, just like cystic fibrosis. We already have a model. We do not have to reinvent wheels. We can create, similar to cystic fibrosis, multidisciplinary care models, which will reduce healthcare costs tremendously, and especially it will reduce the patient cost, which is missed school days, opportunities, employment opportunities, social isolation, stigmatization, etc. Improve patients' quality of life, and we need patient-focused research and patient and community participation in the research. And to do this all, we can do this better if we have a sickle cell disease national registry. Like we have for cystic fibrosis, we have national registry and international registry. From the registry, we learn a lot. We learn the pattern of the disease. We learn the trajectory of patients. We learn what works and what doesn't work. We learn the life expectancy of the patients. We learn how many people have severe anemia. We learn how many people have how many organ damage, and we can learn much more. But registry is not enough. We need the multidisciplinary centers throughout the country to feed the data into the registry. We can create the registry, and we are fighting for creating a registry in Ottawa, and hope we'll get successful soon. But we need to create multidisciplinary clinics across the country, which would create the data in real time to feed into the registry, because the registry is as good as the data. If we have good data in the registry, we have good research from the registry, we get good learnings from the registry. So, the House passed the bill, as you might have seen in the June 10th, to designate June 19th as a federal holiday to commemorate the end of slavery. And this is very historic, but we really need to do the actual action. And the actual action will be investing in diseases like sickle cell disease, which disproportionately affect racialized, low-income racialized minorities. That would be more historic. And these are some references that I fetch data for today's talk from. And thank you so very much for your attendance on a Saturday morning. And if you have any questions, I'll be available to answer. And please feel free to email or reach to us. The Bridge Engagement Center is our go-to place. You can visit our website or Instagram or whatever those social media you seek to. Thank you.
Great. Thank you very much, Dr. Pakhalè. We appreciate you giving your expertise and your talk this morning regarding sickle cell and lung disease. There'll be questions coming up at the end after our second speaker. And so we'll just start having those put in the Q&A. And so I will introduce Dr. Kabi, who is a pediatric hematologist who works out of Sickle Hospital in Toronto, Ontario. Dr. Kabi is also a Sickle board member, and she leads the Quality of Life Committee, and she will be introducing our next speaker. Welcome, Dr. Kabi.
Joy, I think you're on mute, and maybe Dr. Kirby is also on mute.
And she's asking to be unmuted. If one of us can do that, kindly.
Yeah, maybe Carla can unmute Dr. Kirby Allen, please.
Yeah, Dr. Kabi, you can unmute yourself. You're a co-host.
Yep, I'm trying to unmute. I can only ask her to unmute.
Okay, no problem.
Good morning, everyone. And I apologize for this. I'll try to fix the screen on my side. What's happening? I'd like to introduce Dr. Annie McLaren. Dr. McLaren is a graduate of University of Toronto in medical school. She trained at Sickle in pediatrics, and then subsequently in pediatric respirology and medicine. Not long ago, as a resident, she undertook a research project in sickle cell disease and the recognition that they seem to, historically, our patients would lose deterioration of lung function as teenagers. It was recognized that the lung function didn't seem to be deteriorating as much, and she undertook a formal study to look at this. Welcome, Dr. McLaren, and thank you for doing this.
Dr. McLaren, the floor is yours.
Hi, can you hear me?
Mm-hmm.
Awesome. I'm trying to, okay, great, perfect. Hi. I'm just trying to share my screen. do I have permission to do that? Like, is it?
Yes, you do. You can go ahead and do that.
Okay, I'm just trying to. Oops. Sorry, the tab isn't coming up for me to do that. Let me just try and see.
Go ahead and try again.
Okay. Okay, here we go. Okay. Actually, 1 second, sorry. I just have to put it in presenter mode and then it should be good to go. All right. Okay, does that work? Are you guys able to see that?
Perfect, looks great.
Okay, great. All right, thank you, Dr. Kirby-Allen, for the introduction. As Dr. Kirby-Allen mentioned, my name is Anya, and I am currently an assistant professor at the McMaster University, but I did all of my respiratory medicine, pediatric, and sleep medicine training at Sickle. As a respiratory medicine fellow, I undertook a study with Dr. Hartmut Grassmann, who was a senior investigator on this study, looking at how lung function in children changed with hydroxyurea, specifically children with sickle cell anemia. So I'll just walk you through very briefly a bit of background and talk about a bit about what our study entailed or looked at. Okay, so I won't go, I don't have a lot of sort of background introduction because I believe Dr. Pakhalè sort of covered that quite well. So as you know, sickle cell disease is a group of disorders that leads to a distorted sickle hemoglobin molecule. The CDC estimates that the rates of sickle cell disease in African Americans is about 1 in every 365 individuals. As you know, the sickling in sickle cell disease leads to vaso-occlusion, and not only is there a significant morbidity, but the life expectancy for individuals with sickle cell disease is decreased by 25 to 30 years. And unfortunately, pulmonary disease is a significant cause of morbidity and mortality. It's estimated that up to 85% of deaths in individuals with sickle cell disease occurs because of lung disease or lung pathology. So I like to look at lung disease and sickle cell disease as either airway related or non-airway related. So the non-airway related causes include both acute as well as chronic lung disease. So acute chest syndrome, we know very well, is one, pneumonia, pulmonary embolism, obstructive sleep apnea, which actually does occur a bit more commonly in individuals with sickle cell disease, pulmonary hypertension, as well as pulmonary fibrosis. And airway-related disease includes airway obstruction, airway hyperreactivity, which I've differentiated from asthma, and also recurrent wheeze, because if you look in literature, recurrent wheeze and without sort of the typical asthma presentation does occur more commonly in individuals with sickle cell disease, separate and apart from asthma, airway hyperreactivity. So these three conditions seem to have, I do have some overlap, but they seem to be sort of distinct, and I think it points to the pathophysiology of sickle cell lung disease, in that it's thought that maybe there is some airway inflammation that is separate from asthma that contributes to reduced lung function and the presence of airway hyperreactivity and recurrent wheeze. And then lastly, there's a longitudinal decline in lung function that starts from quite early in the life of an individual with sickle cell disease. So shown here is a study that was done back in 2015 by Kasim and colleagues. And this study looked at, it was a prospective cohort study of adults with sickle cell disease. And basically it was part of the cooperative study for sickle cell disease, which looked at individuals who were in adults. So the mean age was about 32 years. was 430 adults, and what they did is that they looked at, it was a prospective cohort study, so they looked at their first PFT, and then they followed them for 5.5 years, measured PFTs, and then looked at the factors that were associated with increased death. So over the course of this study, about 63 individuals passed, and what they found in their final analysis was that FEV1, which is the forced expiratory volume in 1 second, was a predictor of death. So for every 1% decrease in FEV1, there was a 2% increased hazard of death in this cohort of adults with sickle cell anemia. And so this is quite concerning because we actually see FEV1 levels start to decline and be quite low actually in our children with sickle cell anemia. So it was very interesting that they were able to sort of tease out this relationship. And again, it's not clear what the exact factors are that contribute to this increased risk of death. And here is a survival plot that basically just illustrates what I mentioned on the previous slide. So this line here below is for individuals with an FEV1 or forced expiratory volume in 1 second of less than 70%. So they were actually able to tease out at what FEV1 level the death or survival was affected. So I'm just going to switch gears a bit and talk a bit about this one study that was done at Sickle Hospital as well with Dr. Grassman before I was a fellow there. But this study is looking at lung function decline in children. So these the children that were involved in this study were aged between 6 and 20 years. The dark circles are males with HBSS, and the dark triangles are females with HBSS. And this dark line represents males, so the solid dark line, and the solid gray line represents females with HBSS. This line here is HBSC individuals, and these are normal controls. So the take-home message from this slide is that there is a longitudinal decline in pulmonary function that is accelerated in individuals with sickle cell disease. And it's quite significant. So if you compare children who have cystic fibrosis with children who have sickle cell disease, the rate of lung function decline is more pronounced. And it's interesting because we don't, it's not something that we hear much about or that is spoken much about, but the rate of decline and lung function in individuals with sickle cell disease is actually worse than in kids with cystic fibrosis. And briefly, hydroxyurea, which is the only disease-modifying therapy that has been approved so far for use in children and our adults with sickle cell disease, works by several mechanisms. So the well-known mechanism of increasing fetal hemoglobin is only one, but it also lowers neutrophil as well as reticulocyte counts, as well as decreases adhesiveness and improves the rheology of circulating neutrophils and reticulocytes. It also reduces hemolysis through improved erythrocyte hydration, macrocytosis, and reduces intracellular sickling. It also has some effects on nitric oxide release. And so there are a few mechanisms by which the hydroxyurea is actually working. So for the study that we did, our hypothesis was that hydroxyurea has measurable positive effects on the progression of lung disease in patients with sickle cell anemia. And our objective was to examine what these effects were over time. And so our patients were followed clinically over a 4-year period. The patients that were selected for this study were patients with sickle cell anemia, so either hemoglobin SS or hemoglobin S beta thal, null beta thal. Participants were followed at 3, 6, 9, 12, 24, 36, and 48-month time points after hydroxyurea was initiated in the sickle cell clinic. We have laboratory measurements, or did laboratory measurements on these patients that included CBC, renal function tests, hemoglobin F, liver function tests as well. And then we collected the pulmonary function testing up to a median of about 3.68 years before they were started on hydroxyurea, and about 3.8 years after. So we have a total of almost 8 years of pulmonary function data, about 4 years before and about 4 years after hydroxyurea was initiated. And so this is what our population looked like. So the median age, or the mean age at the start of hydroxyurea initiation, was 11 years old. 47% of our cohort were male, and most of them had the SS genotype, with about 4% having the S null beta thal genotype. Some of the clinical information that we collected in this cohort was the number of vaso-occlusive crises that were occurring before hydroxyurea was started and then after. So as you can see here, individuals with sickle cell disease had anywhere between 2 to 4 vaso-occlusive crises per year prior to the initiation of hydroxyurea, and it was significantly improved after the initiation of hydroxyurea. And what we found is that lung function decline improved. So before hydroxyurea was initiated, it was almost about 2% predicted drop in FEV1, which improved to closer to 1 with the initiation of hydroxyurea. Other measures of lung function, such as the FEF, or the forced expiratory flow, also improved significantly from close to 3.5 here to 2.8. We saw similar increases across the board in the forced vital capacity in these children. And so the effects of hydroxyurea on the airway are not clear. So as I had illustrated in the initial slide, there are multiple mechanisms of hydroxyurea, whether hydroxyurea is working via hematologic or rheologic or anti-inflammatory pathways. What this data does suggest is that there is a positive effect on airflow limitation, and specifically in the longitudinal decline in lung function in kids with sickle cell disease. And so the take-home messages really are that lung disease starts early in sickle cell disease. In this cohort that we looked at, children who had sickle cell anemia that were started on hydroxyurea at 11 years of age had a decrease in their rate of lung function decline about 4 years after, up to about 4 years after it was initiated. When the study was done and published back in 2017, it was the first that showed a positive effect of hydroxyurea on sickle cell related lung disease. And so, consideration for guidelines of earlier initiation to preserve lung health it being warranted, it was sort of our take-home message then. So that really is my presentation. It's short, but hopefully it drives home some important points about hydroxyurea in lung function in children. And I'd love to participate in further discussions and answer any questions you might have.
Great. Thank you, Dr. McLaren. Really nice presentation, and also Dr. Pakhalè for the earlier presentation as well. Maybe Dr. Pakhalè, can you come off, or can you turn on your video and we can open up that? Perfect. And we can open up the session for Q&A. And what we'll do is Joy and I will moderate on the questions we've received so far, and we'll try to point them to the right speakers. But of course, both of you are very experienced and can certainly answer and complement each other in these discussions. So really appreciate the engagement. The first question we have, I think it's just a general question, and we had a question about accessing the slides. Obviously, to our attendees, as you know, the session is being recorded and is streamed live on the Facebook SCAGO site. But I guess just a general question is, will there be availability for the slides that both of you have presented in case the attendees want to take some further notes or be able to understand some more of the content? Is that something you can maybe send offline to us, and we'll make them available perhaps?
Sure.
Okay.
Sure, no problem.
Thank you both. The second question is, how do we create a sickle cell registry? And maybe
so that's a very good question. We are now working with the national group of sickle cell, Biba and Susan, etc. And we are pushing for that to create a sickle cell registry. Sickle cell in any registry, it has to be housed at some place, and then maintenance of it. Like, you know, the registry is registry of ideally of all the patients in Canada, and then ongoing data should be added in it, ideally by all the centers. So how's the data created? If there is no multidisciplinary clinic, and if there is no regular follow-up of sickle cell patients in a programmatic manner, there is no data, right? I mean, I'll tell you the example of cystic fibrosis registry, which I also am closely associated with. Each site, each multidisciplinary center inputs the data on all the cystic fibrosis patients at their site, on their lung function, on their other numbers, say their weight, their hemoglobin A1C, because a lot of cystic fibrosis people get the diabetes, their bone density measurements. There a lot of these measurements and test data get inputted into the registry by each multidisciplinary center every year. So the registry then is populated by this data every year ongoing. And as you can see, it's a very rich data set. So that's what we are struggling to get. And once we get the get-go, you know, at our local sites, then I hope we can shake hands, and wherever the sickle cell disease doctors are, they can at least help us. However, organizations like SCAGO and all the aware citizens can push for getting a multidisciplinary care clinic at their own site.
Great. Thank you, Dr. Pakhalè. Joy, do you want to triage the next couple of questions?
Yes, I will go with a couple questions. So the next question is, how do we encourage sickle cell patients to accept hydroxyurea as a treatment? Many are reluctant to take it because of side effects. And this is a question by Beverly. Any of you can take it.
So I have had some experience with this because even though we do not have multidisciplinary clinics, since I joined in year 2008 here, first thing I did was meet the hematologist who is doing the sickle cell clinic in hematology. And I said, because I know the lung is a major organ involved, I said, any chance of we creating a multidisciplinary clinic? And that is still in making, and we are still fighting. I started seeing all the sickle cell patients, whosoever has any lung issues. So I see a lot of sickle cell disease patients. I call that my underground effort of sickle cell disease multidisciplinary clinic. In my respirology clinic, I see a lot of sickle cell disease patients by default, because since the beginning, I voiced my concern and I told them like I am ready to see. So they send me the referrals. Now, a lot of these patients, because we are seeing them longitudinally over a period of time, you develop that doctor-patient relationship. And that trust is very important. That bond is very important in anything, as you might have seen, in getting the COVID-19 vaccine. Because if you have a trusted person telling you to take the COVID-19 vaccine, that person will take it, right? Because they trust you. They trust the message that you are telling them. They know that you are you have their best interest. So that trust and engagement gets developed over a period of time. And hence those longitudinal multidisciplinary clinics, again, I repeat myself, but that is very important. That's where the trust gets developed, because you see the same people, the same caring team over and over again. They have helped you through your thick and thins, and you develop that bond. And that's how. So I have had some successes in patients who were actually very reluctant taking hydroxyurea, and then my repeated counseling and discussions with them, they are now on hydroxyurea, and their lung functions are better, their quality of life is better, their ER visits are less. So that trust and engagement with a physician and the team, caring team, does not have to be a physician, the nurse practitioner, the social worker, whosoever, it's very important. And that, plants the seed of taking anything then, not just hydroxyurea.
Thank you. That's an excellent response. I think building this relationship between our patients and us allows them to believe that they can trust us and trust that what we're telling them is the truth. Do you have anything to add, Dr. McLaren?
Sure. I saw Dr. Kirby Allen on mute, so I wasn't sure if she wanted to chat as well. But I agree with Dr. Pakhalè. So I actually joined McMaster in 2019, and I did the same thing. So I went to all hematologists there, and she actually sets aside patients that she wants me to consult, and I join her in her clinic. And we go through, for a lot of families, I think the most important thing is education, and to try to educate parents around the decision, because really they are the ones making the decision for their children to start the hydroxyurea. And so I spend quite a bit of time with families educating them about the benefits of hydroxyurea, and just, what happens when we initiate, the fact that we're monitoring the kids closely. And some to be honest, some parents don't buy into that and are reluctant still, but I think something that will come with time once they do sort of develop that therapeutic relationship with their primary care provider. I think also what helps is showing them the numbers. So when they come with their pulmonary function tests, and you show them sort of where the numbers are and how low the numbers are, then that sort of can help them to sort of buy into that, because it gives them something that is more concrete. Having said that, a lot of the times when kids come with low numbers from their pulmonary function testing, they usually end up not really having a lot of symptoms. And so sometimes it is hard for parents to buy into starting them on a therapy when they don't actually see any issues with their lungs. And I mean, part of me thinks that may be related to a bit of deconditioning in kids with sickle cell disease, that especially the ones that aren't very active. So it's a combination, I think, of the multidisciplinary care, being able to develop the therapeutic relationships with families, and being able to provide concrete education first, and then concrete data on what their child's pulmonary function is looking like, and how far it is from the standard or from what we would consider normal.
The other thing, this is Melanie. The other thing that is helpful first of all, be totally transparent in discussing hydroxyurea, the benefits and the small number of risks. Any medication you give will have potentially side effects, and we monitor those side effects. So that's why patients go and get blood work a month after starting a new treatment, an increased dose, and every 2 or 3 months long term. Another thing that is helpful is if offer to your patient to speak to another patient who has been well established on hydroxyurea, and they have seen the benefits themselves, less hospitalizations, less need for transfusions, less coming into for acute chest, and overall well-being, increase in appetite, and etc. That can be helpful if a family wants to speak to another family who's been well established.
Okay, thank you very much. We will go to the next question. This is addressed to Dr. Pakhalè. Dr. Pakhalè, apart from multidisciplinary clinic, which you advocate but not yet achieved, what are some practical routines that you can suggest to sickle cell disease patients to maintain lung health?
Yeah, that's a very good question. And like Anna was telling earlier, deconditioning is very common in sickle cell disease patients because of repeated pain crisis, and maybe they do have limitations in physical activities because of their poor lung health. But a lot of kids then will say, even adults, oh, I don't like running. Oh, I used to play before, but I don't play anymore, soccer, or whatever that may be. And people start legitimizing because they have actual physical limitations because of their poor lung health. So acknowledging that is very important, and deconditioning being common because of repeated pain crisis and poor lung health. starting slow, just by starting a regular walking program. I always say that if you take my pill, and my pill is regular walking for half an hour, you will do much better for yourself. So everybody takes that pill of regularly walking every day, and that's where you begin, and then you build. That would be very nice. So starting slow and building is on your physical activities is a very important thing, because by doing so, you will not just get the physical fitness and the overall benefit of physical exercise, but you will also realize how much limited you are in doing certain physical activities. And if you are limited and you are getting certain symptoms of, say, shortness of breath or wheezing or coughing, then you can report them to your doctor and you could get proper diagnosis. Is it asthma, or is it simply just airway hyperresponsiveness, or is it something else happening in your lungs? So because if you don't challenge yourself in terms of physical activities, you may not get certain symptoms, and if you do not get certain symptoms, you may not get diagnosed. So the diagnosis is getting delayed, and then you will suffer the consequences even more.
If I could jump in also here, and also avoid smoking. Some of our young people are smoking different things, and smoke in your lungs is damaging to anyone. So living clean also in terms of your lungs.
I couldn't agree more. Not just smoking, the smoking tobacco, smoking marijuana, or any kind of vaping. A lot of people think vaping is clean, but it is not. Vapes are made for making money from you, and there is no government oversight on it. There is no manufacturing standards. So a lot of poisonous agents are there in the vape. And so shisha is very bad. Smoking, anything going in your lungs other than clean, fresh air is injurious to your lung health. So please remember that. And because there is a lot of targeted advertising towards youths, especially actually racialized youths, with all these jazzy objects under the name of vaping and smoking and whatever that is because of very savvy business decisions. So we have to be very careful and educating the youths about it.
Maybe just a quick follow-up on that, maybe for Dr. McLaren. Knowing how significant lung complications are, as both of you highlighted this morning, how often are respirologists, for example, the first physician to diagnose sickle cell disease, or does it normally come through hematologists, for example? But just knowing how significant these lung complications are, or asthma or wheezing, you typically find that maybe you're the first point of contact for patients in that referral pathway, perhaps.
I mean, we're usually not. So I would say that most of the time, the patients that I see with sickle cell disease or sickle cell anemia usually end up coming through the hematology clinic, or they get admitted to the general pediatric floor and post discharge, because maybe they needed oxygen when they were asleep, for example. I'm asked to see them, but I'm usually not the first point. They're their first sort of healthcare professional that they encounter as they learn about their disease.
Usually by the time you start having clinical lung disease, you would have presented a lot earlier with other symptoms and signs associated with sickle cell disease.
Thank you. Joy, you had one question you were teeing up, I think.
Yes, I think, Elena, you had a raised hand. Maybe you can unmute yourself and ask your question. Elena? Okay, if you come back, just raise your hand again. I'll go to the next question. Is it okay for a sickle cell disease person to take physical exercises where there is pulmonary challenges?
So, I mean, currently, and Dr. Kirby-Allen, you could also speak to this as well, since you see a lot of kids with exercise. I was going to say that there aren't official guidelines, and general recommendations are for kids to, who who want to be active to exercise to the point where they feel limitation. So I guess it would depend on sort of what exactly is the pulmonary or the complicating respiratory condition that they have. But in otherwise healthy kids with sickle cell disease, we usually encourage them to be physically active, to make sure they're well hydrated, to take frequent breaks with their activity, and to stop activity at the first sign of any difficulty or limitation.
Yeah, I mean, that's what I tell also to my adult patient, like, listen to your body. Listen to your body. If you start slow and then build up. And once you do that successively, you already know what your limitations are. And whatever those limitations are, voice them to your physician, because those limitations could be not just because of deconditioning, but because of actual disease, and that would get then diagnosed. So just see how much you can tolerate and go by that. Don't push your limits. If you're getting symptoms, just report to your doctor.
If I could just add to that about the use of hydroxyurea, one of the first things that the patients tell us when we start hydroxyurea in the clinic, and the parents, is that their exercise tolerance increases. And what happens is, as your fetal hemoglobin or baby hemoglobin increases, your overall hemoglobin increases, and you have a better oxygen carrying capacity. So overall, starting hydroxyurea improves your quality of life by increasing your hemoglobin, so you have more oxygen for exercise. So not only preventing later effects like lung disease in teenage years and adults, but by starting hydroxyurea, your overall quality of life improves. And there are kids that we have who are on hydroxyurea who fully participate. One of the kids that taught me this was a young man who actually got a track scholarship to go to University of Buffalo, which I've never heard of a track star with sickle cell disease. So I'm not saying that hydroxyurea will make you run fast. I'm saying that if you have the talent, and you can excel in a sport if you have the talent, it helps you. Hydroxyurea.
And just to add to that, exercise, I mean, even for healthy individuals who don't have sickle cell disease, exercise is a good thing to do. It's good for your lungs and it's good for general lung health. And so being on hydroxyurea and being able to exercise, at a better capacity will only have positive effects on your overall lung health as a patient with sickle cell disease.
If I could also just, earlier you heard from both talks about the shortened life expectancy with sickle cell disease. Hydroxyurea is extending life expectancy. Is with the patients that are currently starting hydroxyurea from young, obviously they're very young, so we can't talk about life expectancy, but I'm actually very positive, and I don't talk to families about their kids growing up and not living to full adulthood. And just if I could also comment on one of the previous discussions about kids who are who on hydroxyurea with good transition care, which we've started a transition program in Toronto. 86% of our patients year before last, who graduated high school went on to post-secondary education, which is just amazing. So it speaks to improving health overall, with an emphasis on academics, which we push a lot within our clinic, and encouraging tertiary education. Some of our patients and their families come to the clinic with the expectation that their life is going to be shortened, so they're not looking to the future. That's not our attitude when we see them. We're expecting them to be their parents, to be grandparents, etc., with full children growing up and being full citizens within the society, contributing.
Okay. Thank you very much. Sanjeev, you want to go with the next?
Yeah, sure. Thanks, Joy. The next question is, sickle cell disease also causes delayed puberty in children. I experienced it. what information and care, pharmaceutical and non-pharmaceutical, are available to manage and or prevent it in children with sickle cell disease? Question is to the pediatrician or anyone else. So maybe I'll open up to any of our doctors on the panel.
I can take that. It's well recognized that our both boys and girls go through puberty about 2 years post the general population, but they do go through puberty. And like anybody in the general population, there are some kids will have, for example, growth hormone deficiency, just like anybody else in the general population. And if once that's recognized and treated, then they will grow up and go through puberty. Just to be aware that if you're significantly anemic through childhood and significantly underweight, then puberty will be later, but it does happen eventually. Usually for boys, about my observation, about 16, and girls about the same age. But it's later than the others, but they do go through. If somebody was not going through puberty, not getting a growth spurt by 14, we investigate for growth hormone deficiency and other hormonal issues, and then treat as needed, just like we would for a non-sickle cell patient.
Great, thank you, Dr. Kirby-Allen. The next question, could a child from a sickle cell disease father, normal genotype, mother, have sickle cell disease? And if yes or no, could the child present sickle cell disease symptoms?
So to have sickle cell disease, both parents have the sickle cell SS, both parents have to be carriers. However, there is newborn screening has taught us this. Some parents go and have screening for sickle cell disease and come back negative because they do a sickle screen, but they could be carriers of thalassemia, for example. So if you have one parent who's got thalassemia, that blood test would be negative for sickle. So when parents are being screened, they should ask for a hemoglobin analysis, not ask for a sickle cell screen, because you can have different forms of sickle cell disease with one parent being a sickle carrier and the other parent being thalassemia, for example, or another abnormal hemoglobin C, or another abnormal hemoglobin where there's increased persistence of fetal hemoglobin coming together. Both parents don't have SS, but they have another abnormal hemoglobin. So one S, one abnormal hemoglobin, that's a sickle cell syndrome with different clinical presentations. I hope that answered the question.
Yes, thank you, Dr. Kabe. We do have a raised hand by Slayan Bola. You can go ahead and ask your question.
Hello, everybody, and thank you so much for this presentation. And I just have a question with regards to pulmonary hypertension. I was told that I have. Can you hear me?
Yeah, but it's
yeah. All right. Okay, I'll try and put my mic a bit closer. So about a few weeks ago, I was advised that I have pulmonary hypertension, an over 50 sickle cell patient, and like the doctor who presented on pulmonary hypertension says, one of the things I do is I take my 30 to 1 hour exercise just in form of a bit of lots of walking and a bit of slow work, depending on how my shortness of breath is. But what I just wanted to ask is a simple question. This is a new norm for me now, and thank you so much for the information on this pulmonary condition which I have. But how do I manage it? I think psychologically, it's a bit frightening for me. And I just wanted to just hear a bit more as to how to manage day by day.
You're losing you.
It's something that kind of a bit of fear, which is normally not my case, but I just can't help it. So that's my question. Management for pulmonary hypertension.
Thank you. I will let
Maybe I can tackle that. I know we were losing your voice a little bit, but what I got, like the recent diagnosis of pulmonary hypertension and how to manage that in a day-to-day life, right?
Yes, indeed.
So the pulmonary hypertension as such, as a topic, aside from sickle cell disease, is very fast growing entity in terms of research, which is a very good news, because pulmonary hypertension itself has now better classification system, better understanding, better therapeutic modalities, and just overall better understanding of the disease entity as such, just pulmonary hypertension per se, because there are a lot of different reasons why people get pulmonary hypertension. Different kind of lung diseases, different heart diseases, people get pulmonary hypertension. And so many people get pulmonary hypertension just by itself. They don't have any lung disease or heart disease. So long and short is, the research in the area of pulmonary hypertension is growing fast and rapidly, and we have a lot of other tools in the basket that we didn't even have maybe 1 year ago, even 2 years ago. It's rapidly growing. Now, the pulmonary hypertension with sickle cell disease specifically, we may not have a lot of specific agents. However, because we are understanding the pulmonary hypertension disease entity as such much better than before, we know how to better manage it. We know how to better care for it ongoing way, and what are other symptoms person can get. So monitoring for your sake, I do not know if you get seen by the pulmonary hypertension clinic, because that would be the best thing, at least, 6 months, once every year. And then monitoring the measurements, which we do on the simple test, the 2D echocardiogram, the sonogram of the heart, and that is the medical stuff. Monitoring also your oxygenation, because in sickle cell disease itself, if you have lung entity, your oxygenation could be less. The oxygen they measure with the finger, that is very important. We also do something called 6-minute walk test in the pulmonary function test lab, which then measures your oxygenation at the end of that 6-minute walk, which is kind of your regular walk and how your oxygenation is. So these are some of the tools that monitoring should happen with. But for your day-to-day, again, as I always say to all my patients, listen to your body, So of course, you need to do regular physical exercises, because that has a lot of more general benefits for the rest of your body, right from your brain, for your heart, for your lungs, for your gut, for your muscles, your ligaments, everything. So regular physical activities regularly as tolerated, and that's very crucial, as tolerated, because you know your body and you know what symptoms you feel. And as a person with pulmonary hypertension, you should not be pushing your limits. Usually we tell people to push their limits, but if you do have pulmonary hypertension, don't push your limit, rather know your limits and then report them to your physician. So if something is changing, like today you could go up and down the stairs 5 times, and then you couldn't go. There's something happening. So your physician need to know that there is some change. So those kind of your limits you need to know. And then if there is something is changing, your physicians need to know that, if that makes sense.
Okay. And a follow-up question on that, Dr. Pakhalè.
Can I ask a question? We recommend hydroxyurea.
It definitely makes sense. Thank you.
Sorry, are you on hydroxyurea with pulmonary hypertension, because you probably should be on, or chronic transfusion program?
Yes, I've been on
Closely.
I've been on hydroxyurea for the past 9 years. Well, for me, and my hemoglobin is staying great. So yes, I've been on hydroxyurea for 1.5 years. That I've been on hydroxyurea. Yeah.
Okay. Thank you, Slian, for your question. Thank you for your response, Dr. Pakhalè and Dr. Kabi. And a follow-up question on that would be for Dr. Pakhalè. We've known that sildenafil has been used in the treatment of pulmonary arterial hypertension. Is there a role for sildenafil in patients with sickle cell disease?
Sorry, did you say sildenafil?
Yes.
Yeah, no, so the specific therapies for what they are for pulmonary hypertension, they are not, I mean, there is a lot of research is missing in this area. And so no specific therapies are there available to us as of now. And that's why following up with the pulmonary hypertension clinic is very important, because therapies are coming along new every few months. And hopefully there is something new. But we don't have anything specific as of yet.
Thank you very much. We will move over to the chat where we do have a couple of questions. And the first one is from Beverly. And she does say, my son is diagnosed with sickle cell disease. He started hydroxyurea at the age of 14. He has done exceptionally well with no crisis. This drug is a wonder drug, and it gives a quality of life for my son, who is now 19. I'm extremely grateful to Dr. Kabi and Dr. Odame and McMaster and the Sickle Cell team for the exceptional care and treatment for her son. I think this is a complimentary message, and thank you, Beverly, for typing that in. A question for Dr. Kabi is, my daughter is 21 years old and is going into her 5th year of a 6-year program at the university, and she's on track to graduate with her cohort. Dr. Kabi, I believe these are patients who are just thanking you for the wonderful care that you've given to their children. Kofi Mensah asks a question. Please, what is your view on the CRPS medication as compared to HU? Thank you. I don't know what CRPS is. Maybe Kofi Mensah can type in what he meant by CRPS. Meanwhile, we shall answer the next question, which is from Facebook, from Deborah. After recovering from an acute chest syndrome, what can I do to help my child increase her lung function? She has had 2 sessions of physiotherapy already.
Is that a question for maybe Dr. McLaren?
Yes.
Or is your child on, well, I guess this is a Facebook question. I'm not sure if she's live and able to answer if her child is on hydroxyurea or not. But, you know, as we discussed before, hydroxyurea would definitely be a medication that you would want to consider starting her on that medication. And again, the other thing that we spoke about as well is being physically active, as long as you're able to tolerate, she is able to tolerate the physical activity. Those are sort of the 2 recommendations for maintaining good lung health and lung function in kids with sickle cell disease. Dr. Correa, I don't know if you had anything else to add.
Just exercising to your tolerance level. We encourage kids to take part in soccer, whatever their friends are doing, to their tolerance level. If they make a house league or an elite team, their coach should be aware that they have sickle cell disease and they may want to come out before their group is coming out. So just when they're tired, they should be able to come out. But we encourage them to participate. I encourage them to take part in all the school sports, all the trials, everything, to their tolerance level. We don't want them sitting at home. You get thin bones, poor lung health, depression, not good things when you sit at home and do nothing physical. Exercise also helps with academics, better brain function.
Also, staying away from smoke, active smoking as well as passive smoking, you know, it's very, very important. We should not ignore that. That is my other life. A lot of studies we do at the Bridge Engagement Center around tobacco smoking. We published guidelines recently on how to treat tobacco dependence. The American Thoracic Society, I was major part of it. So the smoking, vaping is very important, and especially that age group of kids, you need to be very, very careful. Marijuana smoking is becoming much more common in youths since it became legalized. That's what at least I see the lineup in Ottawa's fancy stores. The youths are lined up. So those are very important. And I know there was some question about passive smoke exposure, that somebody is exposed with smoke, somebody else is smoking who they are living with. And so for tobacco smoking, we need to understand that it is a very severe addiction. I call it a king of addiction. It is the most severe addiction because at the Bridge, people tell me they had no trouble quitting crack, cocaine, marijuana, heroin, or whatever that may be, but they had a lot of trouble quitting tobacco. So that tells you it is very difficult to quit. And a lot of people who smoke, they want to quit. Majority of them, they have tried quitting and they have failed quitting. So compassionate approach is very important towards the people who smoke, and ask them if they have tried and if they need some help and what the help is available in your neighborhood, or some programs are available. Now the tablet, which is the Varenicline Champex, which is very effective and very, very well tolerated. There are a lot of myths around that tablet, but it is very well tolerated. I prescribe it very freely to everybody. So having those compassionate conversations with somebody who is smoking around you are very important, because then they will see that you are on their side. You are seeing their suffering, because those who smoke, they suffer and they feel those sufferings and they want to quit, but they have very high level of difficulty quitting because it's a very, very addicting substance.
Thank you very much. We do have a question. Kofi has clarified what his question meant. Please, what is your view on the CRISPR therapy compared to hydroxyurea? I believe this is a question on gene therapy. And Dr. Kabi, you're welcome to take this question.
Okay, so it's a different level of treatment. Hydroxyurea is readily available and is relatively inexpensive, not so expensive a medication, and available for everybody. CRISPR is still CRISPR is gene editing, where a sample of cells from the patient are taken. Those cells are modified in the lab, and to put in such a way that those cells produce more fetal hemoglobin, and then those are given back to the patient after the patient's been prepared with a lower level of chemotherapy than they would have for bone marrow transplant. So this is one still in the research area. We are participating in some of the bigger centers. It had just dropped to age 12 years and above. So again, at the moment, not freely available to everyone, but it does have more risk than taking hydroxyurea. So if you're comparing those two, there's still more risk. It's still a good option for some of our patients. And each patient in the research protocol, each patient is screened, and patients are identified that would be a so-called good patient for CRISPR, and put forward for research in the research program. But it's still a long way before we could say, look at patients in clinic and say, okay, we'll set up CRISPR for you, in the next few months or years. It's still a research protocol at the moment. So until you can have a definitive sort of cure in CRISPR, you want to keep your bodies healthy, be able to go that route. So one way of keeping the body healthy is with what we have available, which is good option hydroxyurea. Keep organs normal so that when CRISPR becomes more available, if that's your choice to do that, then you have healthy organs going into that procedure.
Great. Thank you, Dr. Kirby-Allen. So our last question here we have in the Q&A is, taking hydroxyurea for about 18 months now. I have not visited the ER. Also, what is the effect of alcohol in sickle cell patients?
I can take that also.
No.
Alcohol is well known to be associated with vaso-occlusive crises. We've had young people going off to university, like all young people going off to university, they get introduced to alcohol in a bigger way than prior. And it's almost predictable that if somebody goes on a Friday night alcohol and has a few beers or whatever else they drink, that later that weekend there will be an emerge with vaso-occlusive episode. So and part of that is because it's dehydrating you. When alcohol is like a diuretic, whatever water you have drunk and you drink alcohol on top of that, you pee out a lot more than you actually take in. So you get dehydrated, you go into a vaso-occlusive episode. Alcohol is also not great for your other organs, your liver, for example. Excess alcohol causes liver damage, and then that, along with an occasional VOC episode, will help lead your liver to become cirrhotic and early death from cirrhosis. So like anything, I'm not saying that anybody can't have a drink, everything in moderation. But if somebody chooses to have a beer, then they should increase their fluid intake much more than they would have to try and counteract the dehydration that you get.
Wow, thank you very much. That brings us to the end of our Q&A sessions. I think we've had a very fruitful morning going through just learning from the experts on lung function and the benefits of using hydroxyurea. At this point, I will invite Dr. Kirby Allen to give us our closing remarks.
Thank you. Thank you all for joining us. Thank you to our two speakers who gave our excellent presentations, and I hope a lot of insight into lung care of your lungs and lung disease prevention, what can be done, and if you're affected, what can still be done to, like exercise, for example, to maintain what function you have and prevent it from deteriorating. Keep up with, if you're taking hydroxyurea, keep taking it. If you haven't started exercising, start to exercise. I walk every day, that's my exercise. Everybody should be doing something, some form of exercise. You don't have to go to an expensive gym. We can't go now anyway with COVID, but do some kind of exercise, even if it's skipping in your backyard or on the street, on the sidewalk, something to exercise yourself. We have it historically, patients with sickle cell disease lifespan has been shortened, but don't ever look at that as the status at the moment. Things are getting better. Hydroxyurea, now more people are taking it, for example. We understand the disease a lot better. So I would like everybody to lead with being positive if they have sickle cell disease and not feel depressed at the end of this. Talk to your individual physicians of what you can do to help improve your quality of life and your health. Thank you.
Thank you, Dr. Kirby Allen. And thank you to all our panelists and our attendees on behalf of SCAGO. We look forward to bringing you next educational series after this. We will share those with you as they're developed. When we close this session, just a reminder, and a sincere thanks in advance for filling out the survey that you will get. As mentioned at the beginning, we go through all of the feedback to try to improve these sessions and work with great speakers to bring you the content that can most help the sickle cell community. So thank you again, everybody. Wish you a safe and healthy weekend. And we look forward to being in touch with more series in the coming weeks and months. So thank you, everybody. Take care.